Well, I know we have a lot of questions. We'll answer as many as we can. I'm going to ask one that was submitted multiple times in the registration is what can a patient expect after maintenance?
Jonathan, you want to tackle this first and then I can comment after you?
Sure. So for those in the non-muscle invasive bladder cancer setting, when we finish maintenance, we just plan to continue with surveillance cystoscopies and not giving any more treatments. We just stop at the 1 year or 3 year, depending on when it was. And then if there's a recurrence, then we reset and reevaluate depending on the different nuances of stage, grade, timing, et cetera. But for non-muscle invasive, just continue with the cystoscopies to monitor for a recurrence.
I think the concept that Dr. Wright mentioned is important. So every time we give a therapy, we want to see if it works. So we do, diagnostic tests, even when the cancer is spread in the metastatic setting, we do frequent CAT scans and we may decide the frequency, how frequently to do it. The big question is what Gail mentioned before, how long we continue treatment, and that actually can be very relevant in different scenarios. But the other point to mention is there's always, importance of a balanced discussion of benefits and risks. And we have to make sure, we communicate that with the patient and make decisions on individualized patient scenarios. When a treatment, the maintenance therapy, at least in metastatic disease, based on this trial I showed you, usually the immunotherapy continues again until a major side effect happens or there is the cancer grows again. However, in some cases people may stop at 2 years, and afterwards they do blood work, CAT scans, just to keep an eye on things. We call this surveillance. The last point I will make is, because I saw a couple of comments or questions, people were asking what happens after they get what we call definitive treatment with the intent to cure the cancer, when the cancer is still localized in the bladder, and they can get, either, radical cystectomy, meaning removal of the bladder, or they may get, what we call a scraping of the bladder tumor and then chemotherapy and radiation in an attempt to keep the bladder. If there is no evidence of cancer after those curative intent therapies, we then just do surveillance. And what surveillance means, blood work, CAT scans, exams, if the bladder is still in place, we do cystoscopies and urine cytologist tests for cancer cells. So this is a different concept. We call this adjuvant. And sometimes we may use adjuvant chemotherapy if someone never received it before. But this adjuvant discussion, which is what do you do when there is no evidence of cancer after removal of the bladder, is a different question. And maybe another topic, Morgan and Stephanie, for our audience, especially in the context of new data coming out about the adjuvant post-operative setting.
Absolutely. And along those lines, is it necessary to get the maintenance therapy after you've done induction therapy? Is it always, or is there a situation in which patients would not get maintenance?
Yeah, I think that there's some nuances to it. I think in general, if you meet the high risk criteria, we're going to favor maintenance therapy. And same with intermediate, you're going to have a discussion about the role of it. But it's very individualized with the patient. And if some had a very, very difficult time with the BCG, and in fact, most of the failures from side effects in the studies happened during the maintenance time, the induction time, the first 6 weeks. So they might just say, hey, it's, when we're weighing risks and benefits, it's just too hard on you. And I think Joseph brought up a really big point too, and that is that some patients just can't travel. It's too big of a disruptor to their life, and not just an inconvenience, but just can't make that happen. And you have to make a decision to say, okay, again, when we're weighing the risks and the benefits, we're going to not be able to do it in this case. And then if it recurs, we then treat it from there. But again, this just calls on the importance of having an open dialogue with your physicians to figure out what's the best thing to do for you as an individual.
And from the more advanced disease perspective, I think that a practical answer is if someone starts with chemotherapy and they achieve, again, a response or stable disease, and there is no contraindication to immunotherapy, I think it's a very reasonable option, and has definitely evidence that prolongs life. And when I say contraindication, I alluded to a little bit during my talk, patients who have a unrelated, not cancer, autoimmune condition like, active lupus or rheumatoid arthritis, something that requires active steroids, it has to be a discussion with the provider, about the benefits and risks, because many of those patients were not enrolled in this clinical trial. So there, could be some exceptions, but for the time being, we don't have any, molecular marker like a test we can do in the lab to select which patients may do better. So we use clinical criteria, especially those who achieve response or stable disease to the first line chemotherapy. And then if we use immunotherapy from the get-go, like with GALE, we have a discussion of how long we continue.
Absolutely. So Dr. Wright, you talked a lot about BCG today. Is there maintenance with other types of intravesical therapies that we should know about, like gemdosi or mitomycin?
That's a great question. I certainly focused with BCG as that is the preferred way to go for the high risk setting. There are certainly data supporting its role in for chemotherapy as well. And when we have the BCG shortage that is affecting us, we have to do alternate treatments. So the data aren't quite as compelling for maintenance chemotherapy, but there are some data. I personally prefer if I have a high risk patients that can't get BCG to try to do maintenance chemotherapy. But again, it's a discussion. Some of my partners are less keen on doing it, again, because it's just not quite as much of a slam dunk, but I like the principle of the idea of maintenance. I think we're all trying to adopt and deal with the shortage. So I think the shorter answer is yes, there are other alternatives doing chemotherapy for it. And when you're faced with a shortage, you have to do those things. Chemotherapy is going to work by killing an existing tumor, whereas the immune therapy might get what's starting to develop. So the biology might make a little more sense with the immune therapy. But again, I feel like for my patients, we talk about doing the maintenance chemo. That's the only option because we could get something before when it's really small too. And I think Joseph brought up an experience that his organization's been able to do of splitting the dosage of the BCG in the setting of the shortage. The challenge is that a lot of patients won't have that available to them because in a small practice, you have, when you split the dose, you can't save it. You have to use it on that day. So you have to coordinate with another patient, or if you're doing thirds, 2 other patients to receive the dose, or it's wasted. So in a large organization that Joseph's in, they're able to do that, which is fantastic. But a lot of places won't have that opportunity available for them.
Absolutely. Thanks. We had a couple of questions along this line. So if you had induction therapy and then for some reason didn't get maintenance, or if you were on maintenance for a little while and had to stop in both the advanced or the non-muscle invasive space, is there a protocol for a recurrence? Do you go through induction again? Do you pick up where you left off? That sort of thing.
I can take it first on the non-muscle invasive. It depends. It depends if you have a small low grade. If you have a small low grade recurrence, which is low risk, we're just going to resect that tumor and go back to surveillance. If it was a high grade recurrence, if you had high grade T1 plus CIS, then we have to have the discussion, kind of how we started out the first time. BCG, chemotherapy, intravesical chemotherapy, or consideration of cystectomy. So I think it depends. We have to reset each time. There's also some nuances to how long it's been since you last received BCG, if we can do it again. So there's not one set answer. Again, it's the dialogue, taking everything into consideration, finding the right treatment for you.
And I think the same principles apply to the metastatic disease setting. It depends on the timing sometimes. For example, if, a patient finishes chemotherapy and then goes on to the immunotherapy maintenance, the timing is important. When this cancer starts growing again, is it like within a few months or it's like years later? And the other parameter is how well the patient tolerated the chemotherapy, the induction phase, right? Any side effects, did they do okay or they struggle with it? So these parameters come to play, and now we have the good news that we have new treatments that have becoming available and FDA approved, what we call antibody drug conjugates, other drugs that are, or target therapies, and there are 2 other drugs approved by the FDA for patients who have progression on prior the cancer progresses. I mean, in prior chemotherapy and immunotherapy, things like enfortumab vedotin or erdafitinib are FDA-approved agents. And obviously, we're doing many clinical trials to try to create more options and try to help our patients live longer and better.
Absolutely. Thanks. I just have one more question, and it's actually for our patient advocates. If there was one thing you would suggest that the folks on this program talk to their doctors about maintenance therapy, what's the one thing you would tell them?
You're asking us what was the question again? I'm sorry.
If there's one thing you had to tell folks who are going to have maintenance therapy to talk to their doctors about, what would it be?
I would talk to the doctor about the availability of BCG. I would ask him also what type of schedule I'll be on. And the really important one is to be your own advocate, because originally they told me you're going to only get 2.5 years of the BCG. And I said, well, wait, I have CIS. The CIS changes everything. That's the changer. And so they told me now 3 years. Now, because I have a recurrence, I'm not sure, Dr. Wright gave me some good information this morning. I'm not sure what they'll do. But I think the big thing is that throughout the bladder cancer experience, I have told people over and over again, because I'm now a survivor, sort of like a little counselor, to get second opinions frequently if a doctor is not serving your needs. Please to ask another doctor. If you can't get BCG from one, go somewhere else. And so you have to be your own advocate, but I would say that that was one of the things that I really, my first doctor offered no BCG. So I went to another one. So that's what I would say for me.
Gail, what about you?
I want to echo what Joseph just said about being your own advocate. I think that that's very important, and that you need to find a treatment center that is going to not only respect that, but anticipate that with additional data so that you always know that you have options, that you have continued information, because this isn't just a one-time decision. In a maintenance treatment phase, you're making a decision on a regular basis because you're being examined on a regular basis. And the what if question, what now question is always going to be in your mind. And so by having that kind of open and frank communication and knowing that you are getting the kind of respectful treatment and the latest data is absolutely essential.